Okay, so shall we make a start? We always start with you, Jonathan, but we should do some introductions because Lawrence asked who you were because we were talking about you as if you were a friend, so which you are. So we'll do some introductions. So I'll go first. I'm Navinder, CEO of Voluntary Action Islington. Sue?
Hi, I'm Sue Lukes. I'm a councillor for Highbury East Ward and the executive member with responsibility for community safety and pandemic response. Shall I nominate the next one? Anita. And you have to nominate
I'm Anita
the next
Grant. I'm the CEO of Islington Play Association.
Lawrence? Oh, sorry.
Sorry, I jumped in.
Oh, is that me? Hello, yeah, I'm Lawrence. I run a project called Healthy Minds, Healthy Pods, based in Sue's ward, actually. Look at that.
Very much so. One of my favourite projects in the ward.
Yeah, I'll get the money to you, Sue. Lovely.
Kevin?
I'm Kevin Turner. I'm a grants manager at Cllr.
And Gerard?
I'm Gerard O'Master Milsom, the Chief Executive of Islington People's Rights.
Ros?
Ros Miller, I'm Director of Islington Faith Forum.
Lucy?
Hello, I'm Chief Exec of Holloway Neighbourhood Group. We run the Old Fire Station Community Centre and the Stress Project.
Mebrahtu?
I'm Mebrahtu, the Islington Refugee and Migrant Forum Coordinator.
Thank you. Jeanette, your turn now.
Hi, I'm Jeanette from Citizens Advice Islington.
Jonathan? Jonathan?
Hi, I'm Jonathan O'Sullivan. I'm Director of Public Health.
We were having a discussion about whether you were still acting director or director. So there you go.
Well, no, formally it's acting, but I'm a bit syllabled out today.
Thanks. Marta?
Hello, sorry, I'm in the office and I got my laptop in a different way. I'm Marta from Volunteer Services Manager at the Volunteer Centre in Islington and part of VAI as well.
Thank you. Where's Annette? Where's Annette? No.
Yes, hi, I'm from Community Language Support Services. Thank you.
Thank you. Leona?
Hello, apologies for the no screen. I have signal issues today, so I'm on my phone, but I'm still here. I am a vaccine engagement manager at Islington Council.
Thank you. And Miriam?
Hi, I'm Miriam. I'm one of the public health consultants at the council.
Thank you. I'm handing over to Navinder now.
Thank you. And I'm going to hand over to Jonathan. Jonathan, we've made you co-host. So
I was going to say, because otherwise we might walk into the standard Jonathan issue about
we can do it at our end if you would prefer.
I'm just trying to find the document. Oh, yeah. I think I might. Who should I send the document to?
If you send it to Marta.
Apologies.
That's okay.
Yay, Marta, I've got you. Here we go. Okay, so hopefully that's winging on its way. Apologies. For those of you who've been on previous calls, you know me and IT is not the best mix.
I'll just ask Marta.
Yeah, I'm just waiting for the. One sec, I haven't received it yet.
Thank you, Marta. Miriam, one of the questions in the chat from Kevin earlier was about free lateral flow tests for organisations. We covered it in a community conversation previously, and we know that they're specific to care homes and other settings that where there are vulnerable people. Any place that there are any available for that are going to be free?
No, I'm afraid not. That that provision simply ended. They're only available to a small number of health and social care settings via the central government system now. I'm sorry.
Yeah, and are they easy to get from the government system? So
I don't know about easy. What do you mean?
So ordering them, can we do them on in bulk?
Well, what kind of settings are you thinking of? Do you mean for care homes?
Well, Kevin was asking. Kevin, do you want to ask the question, because it was your groups that you were asking about?
Hi, Kevin.
Yeah, it's just generally for charity groups that are working with frontline people, and ourselves who are obviously just we're testing regularly. So,
yeah, no,
so
I'm sorry. The provisions ended. It's by and large, it's just care homes that can access them through that system, I'm afraid. Sorry. Yeah, I mean, it's it's possible to buy them. I think they're about sort of £2 or £3 each, depending on the amount that you order. But yeah, the free provision, I'm afraid, has come to an end. I'm sorry.
Oh, here we go.
That's clever.
So, yes, and we're in fact so clever, we're a day ahead of ourselves. So we have an outbreak control board tomorrow, which this has also been written for. Obviously, this is for the community conversation. So apologies, it's not quite the right side set, but there we go. So I'm just going to give you, if you could go to the next slide, please, Marta. I'm just going to give you an overview about sort of summary about sort of COVID impact to date. So talk a little bit about the kind of sort of measures that we've still got in place. I'm not going to do a scenario plan with you, you'll be very pleased to know. And the reference to an emergent variant of concern is purely for a scenario. There is no, you may have heard about sort of the XE variant, and there's obviously concerns about what's going on in China, etc. XE is really, it's just a mixture of sort of Omicron variants. It's not spreading, it's not associated with sort of any big problems, and I'm afraid in terms of mainland China, it is simply Omicron ripping for a population which didn't have a lot of COVID infection, and where the vaccination rates have been pretty low, particularly amongst some of the older and more vulnerable. And Sinovac as a vaccine is less protective against Omicron than the ones that we've been using in the UK. So if we could just move to the summary. So as apropos of the conversation about sort of the loss of access to free universal testing, and Kevin and colleagues, apologies, if it had been up to us, we would have sustained with the free testing, particularly whilst the rates have been so high. But it does mean that we really don't have a lot of information about what's really going on in terms of cases in the borough, in terms of the general community. So these are just some sort of general figures over the last year. So from April 21 up to April 22, about sort of case rates, numbers of individuals or percentage of individuals being tested, etc. And what you can basically see is, you know, if you look particularly at the sort of the one to the top left-hand side, which is the weekly case rate per 100,000, you can see we did have that great big peak in cases when Omicron really sort of like let rip in sort of the run up to Christmas and New Year, and then that long slide down. And then very clearly, I think from roughly end of March, prevalence then started to really increase cumulatively, and then the drop that we then see right at the tail end into sort of the end of up to sort of roughly the end of April, where we are now, is purely because there's much less testing. There's only really, this is primarily PCR testing, is only really testing going on in the hospital sector and to a degree care homes. And to be honest, there's not a lot of, although we did have a fair amount of Omicron at various points amongst staff in care homes, there's actually very little currently going on. We've got sporadic small numbers of cases, etc. Hospitals, there are still quite a number of cases being picked up. So really, we can't say a huge amount. What I would say though is if I look at the national and regional surveillance data, these are based on surveys of the population who are then tested as part of the surveys, is I think, and this is an educated guess and anyone could disagree with me and you could be just as right or wrong as I am, is that I think probably at the point at which free universal access ended at the end of March, that was probably roughly where we were peaking in terms of infections in the community. Now, the reason I say that is we still get data from hospitals about admissions to beds. And that's with anyone with diagnosed COVID. And that's whether or not they're in because of COVID or they're in for other reasons and they happen to have COVID. And in North Central London, our hospitals are very good at that coding. There were some problems with national data, and sort of earlier on in sort of the winter period, there were some problems locally as well, but they have got pretty thorough on it. And effectively, the numbers of beds with anyone with COVID in has been falling roughly since about the first week of April, possibly a little bit before that, end of March. So that's not affected by testing in the community. This is people who have been in hospital, and the proportion of people who are in because of COVID has actually been dropping. So the overall number of beds. So when we sort of hit a peak, sort of roughly around 660 beds across the whole of North Central London in end of December. It had sort of reduced down to around 250, 270 by that trough in roughly about middle of February 22. You can see that sort of in the diagram on the left-hand side. And then it went up to, at one point, roughly about 450, 460 beds occupied. But the proportion, which are primarily because of COVID, has run at about a third of the admission. So actually we're down now currently to roughly about 100 to 120 people across the whole of North Central London in hospital with COVID. Numbers of people who are very ill, so in other words, they're on mechanical ventilation, which is, people who are most seriously ill. The numbers have remained between about 10 and 20 each week throughout this recent period, which is another indicator that sort of COVID infections are sort of plateauing or reducing. And so my sense is we are now probably seeing a fairly reasonably sustained downward trajectory. I cannot tell you how steep that trajectory downwards is. Nationally, it does seem to be reasonably steep now. My suspicion would be better weather, particularly Easter holidays with schools breaking up, etc. The numbers are probably drifting down further, but I could not tell you what the community infection rates look like, but it certainly looks like that peak that we were moving again into back in March has passed now. If we move to the next slide. So the other data that we get is around mortality. Now, this is mortality about people who have had a diagnosis of COVID within the last 28 days. And then we are also getting direct information from death certificate where COVID-19 is mentioned. Now, that's a more accurate measure than we've actually had through a lot of the COVID period, which was simply about had someone passed away was having been diagnosed with COVID within the past 28 days, whether or not COVID was the reason or not. Now, if COVID is mentioned on death certificates, it doesn't necessarily mean it's the primary cause. So it may not be the actual cause, but it will mean that it was viewed by the person signing the death certificate as a contributory factor. So this is actually a much more accurate take on mortality than we've had over the period of time. And the bar chart shows us what all mortality, all deaths reported look like. And the red line gives us the cumulative number of deaths reported amongst Islington residents over the period of time. So from the start of 2021 all the way through to the most recent week, which would be roughly mid-April. What you see is if you go back to the start of 2021, that was obviously when vaccination was very early on in terms of rollout. It was Delta and we had very high levels of infection. The levels of infection were as nothing compared to what we had with Omicron. Omicron was far, far higher than we ever experienced with Delta infections. But what you can see, if you look at the grey bar, the grey colouring versus the turquoise colouring, is look at just how heavy the mortality position was due to COVID during the, the whole of January and February and even into March. What you can see now in the most, again, so if you go to roughly about 80% of the way along the diagram at the bottom, so the bottom axis to 1, which gets you to the start of 2022, even though we had so many infections, see what the pattern looks like. Overall mortality, very similar for non-COVID reasons. Numbers of deaths due to COVID, much, much, much lower. The thing to note now is that we have very small numbers of deaths each week. So we're averaging probably around 1 death per week at the moment, but we're not yet back to the period that we had in the middle of 2021. So if you go roughly about a quarter of the way along that axis, you'll see there's lots of grey bars and absolutely no turquoise. We had a very long period where we actually had no deaths at all among people from COVID. So we are not there yet, but the number of deaths remain very low. And really that's a mixture of the vaccination effort, although we know that there are many more people who'd like to vaccinate in Islington, has been sufficient to protect a lot of the community and particularly our most vulnerable. And you have all in your various different ways played a huge role in that. Secondly, that whether or not people have been vaccinated, there's also a background level of previous immunity due to having had the infections. Now, Omicron was a little different because actually you could have had COVID previously and you remained pretty susceptible to Omicron. And I will out myself. Last summer, I had Delta. No idea how I got it. Absolutely no idea how I got it. I also got Omicron in March. I'm pretty sure how I know how I got that because I got a ping telling me the date and I know roughly what the likely exposure was. But the fact that I'd had Delta, and by that point I'd had both of the first vaccinations and the booster, was not enough to protect me against getting the infection. But in terms of symptoms, I felt pretty rotten for around a week. It kept the infection completely off my chest. And that's where it gets dangerous, particularly dangerous. So big change now in that experience going forward. And that's our overall position. So we are still seeing a small number of deaths in the borough, on average, I'd say about 1 each week, but it is possible as the infection rates go down and as we go into summer, we might hopefully, I hope we get back to that position of the middle of last year when infection rates relatively lower and not seeing any deaths. Now, we have no data around what long COVID trends are looking like, although we have done sort of needs analysis. And obviously, the concern is that given that we've had such high rates of Omicron, that we're going to see a big spike in numbers of people with long COVID as well. The good news, relatively good news, is that actually the evidence based about how effective vaccines are against long COVID has improved dramatically. So one of the real inhibitions we had with the boosters was we could not say anything about what impact the boosters or the vaccinations would have on long COVID because we just did not have the data. It is now clear that the risk of developing long COVID, if you do get the infection and you've been vaccinated, is roughly half of people who haven't been vaccinated. And the duration of symptoms of long COVID is likely to be dramatically shorter. So certainly the median period over which people report symptoms is dramatically lower. And that's a massive increase. And if only we'd had that, I think back in the autumn and winter, it would have been another really strong way to get sort of the take up of boosters and sort of people getting the first and second vaccinations who might otherwise view themselves as being at less risk. Could we just move to the next slide? So I think sort of talked about this. We're on our least sunny side up in terms of using our largest population denominator. About 68% of people have had a first dose now, about 63% second doses, and around 47% have had a third or booster dose. Now, remember, in order to be qualified booster dose, you need to have had both of the first 2 doses. If we use our lower population denominator, which is based on just our general population estimates as opposed to GP registered population, you can lift the first 2 figures by at least about 10%. Okay, so we're probably more in sort of upper 70s in terms of first dose and sort of lower to mid 70s in terms of second doses. In terms of people eligible for boosters, our uptake is roughly about 2/3. Okay, so overall it's about 47%, but for those eligible, it's roughly about 2/3. And with all of these, if you look at by age, we've got much higher uptake amongst older people and our most vulnerable communities in terms of health conditions than we have amongst middle-aged adults and younger adults. Could we move to the next slide, please? So vaccination uptake has significantly reduced everywhere. It's reduced in Islington as well. This is the current provision in terms of vaccine access in the borough. We are reviewing the position around those community pharmacies. So at the moment, there are 5 community pharmacies who are described as offering COVID vaccinations, but we are checking in with the NHS as to whether or not they actually are actively offering vaccination. We still have the pop-up clinic at Resource for London, which is offering vaccination in one of our most needy areas in terms of vaccination coverage, and that's going to continue to the end of June 2022. And we have a number of vaccination outreaches planned across a range of sites and events, and that includes sort of Brickworks Community Centre, Finbury's Park Mosque, Learning Disability Partnership event, amongst others. Next slide. And remember just that vaccination remains absolutely key as a way to protect. We are supporting community engagement work, and thank you for all of you who are involved in that. It is reaching lots of people. It's keeping the conversation going. I'm quite sure a lot of people don't really want to talk about vaccinations now, possibly think COVID is gone, but it is really important that we continue to use the fact that we do have access points in this borough for vaccination. I was talking to a colleague of mine who works in the NHS the other day, so he's completely within the system. He's been very involved in the COVID vaccination efforts. His 85-year-old mother was notified very late about getting her booster. She doesn't live in Islington. Due to go to a family wedding in 2 weeks' time, it took them weeks to find somewhere that would see her. In Islington, if she wasn't sadly an Islington resident or very close to Islington, if she lived in Islington, we could get her to the London Resource Centre or one of the other places of vaccination. So even though there's not the same sort of access as we've had, we've got it. So it's really good that we continue to do that. We're working with our colleagues around those pop-up clinics, and that's working in partnership, not just with our colleagues within the community, voluntary and faith sectors, but also with our clinical colleagues from UCLH Hospital. We are sharing information, advice and campaigns about vaccinations in a whole range of ways, targeted messaging, including to people who are pregnant, and we are doing relatively well in Islington in terms of take up a vaccine amongst women who are pregnant, but there is still some way to go. To be clear, vaccinations are very safe in pregnancy. COVID is not safe in pregnancy. It's as simple as that. And we're also, I think, just in the process of awarding and delivering a small grants programme for targeted community engagement, particularly around working with young people and inclusion health groups. Could we go to the next slide? This is just where testing is currently available. So Kevin, this sort of answers to the point that you and Miriam were discussing about who actually gets access to the testing. If you're picking up in the national press, even some of this is potentially in doubt at the moment. I can't validate the national press coverage about to what extent the range of testing in these settings will continue, but clearly it does, you know, there's some debate about that. We've also, because we did have a limited amount of stock left over from the end of the community testing sort of offer, which also ended with lateral flow test, which also ended at the end of March. We did make some tests available in key services, and where essentially we targeted to was to staff, pupils and families linked to special schools, because special schools have remained very affected by COVID in terms of outbreaks, disruption to education. And it was the one area where we could not see in terms of national government policy that if there was a problem emerging, that they would be able to call on help in terms of test kits. So we were very pleased to do that. And we also made a limited number of tests available to care homes. Next slide, please. And just a reminder about the things that we can do to stay safe, and some of which I think particularly given what I was going to say up until about 2 days ago was quite nice sunny weather, it's going to get better again, is really about some of the things which are really, really effective in terms of reducing risk of transmission. So indoor ventilation is really, really effective at reducing risk. And it's not about have the windows open, have a gale force wind blowing through your house, etc. It's enough to keep your windows open for say 10 minutes for each hour, get the air circulating a bit, close the window if you've got visitors, etc. Outdoor socializing, again, really, really safe way to meet people, very, very reduced risk of any transmission really. So outdoor socializing, indoor ventilation, really great, and particularly as we go into the sort of the late spring summer period. Hand hygiene is possibly less of a transmission risk around COVID, but it is a transmission risk. So keep your hands sanitized, wash regularly. The thing the thing which I am worried about coming up the line is not simply whether or not we do get another variant of COVID, which proves to be, you know, a lot more serious and able to evade vaccination and previous immunity. It is very much about the level of respiratory infections in the community and the risk of having a big flu season, particularly in the autumn and winter. People do mention the risk of having a non-seasonal flu season, if that makes sense to you, so outside the usual sort of December sort of to February timeline, but I'm not seeing any evidence of it. But flu is highly transmissible by hand-to-hand contact and by putting your hand up to your mouth and nose, etc., whereas COVID has been much more probably airborne in terms of transmission risk. And then I have to say I am continuing to wear my face covering indoors if it's a shop or it's another social place where I don't usually mix with people. I continue to wear my face covering on the bus and on public transport. There are people who still continue to do that. I continue to do it even though I'm sort of vaccinated post-Omicron, and the reality that I'm likely to be transmissible to anyone or have the infection is highly, highly unlikely. I continue to wear the face covering really for two reasons. One is to show solidarity to other people who continue to wear their face covering. Secondly, for solidarity for people who are vulnerable, who need to use public transport or other go into shops, that I'm looking out for them by wearing my face covering. So again, that remains really, really important. And then I think we might be on the final slide, but could we just check, Marta? We are on the final slide. So thank you ever so much, Marta, for your assistance, and I'll hand back to you, Navinder.
Thank you, Jonathan. Wow, I think some of my questions were answered in that, in what you've just, you know, very thoroughly covered. Do other people have Mabratu? You've got your hand up.
Yeah, Thank
Yeah.
you. Thank you, Jonathan, for all the information. My question is, still I wear, face masking. But many people, they don't believe it is, for not for you, but for others. And then others also, they believe 25% for yourself, 75% for others. How true is to explain us, please? Thank you.
And I was on mute, so you didn't catch what I had. I didn't catch the last bit of the question.
Okay, my question is, I still wear, the face masking, yeah?
Yeah.
Many people, they believe that it doesn't help you for yourself. Face masking is for others to protect. And then others believe as well, 25% is for you, 75% is for others, so no one is caring. So could you explain more on that one?
Okay, that's a really good question. And of course, one of the things that, if you remember early in the epidemic, we didn't encourage face coverings. It was something that people could have personal choice about. And that was really because the evidence about how effective face coverings were in reducing the risk of transmission, plus the potential risk of it increasing the infection risk to people wearing the face coverings, wasn't understood. So I'll unpack that a little bit, but then talk about face coverings now. So the evidence-based change, the World Health Organization and other bodies did really large systematic reviews about the evidence base. There were also a huge amount of research trials done very rapidly to see whether or not face coverings did indeed make a difference. Firstly, in terms of reducing risk of transmission to others. Secondly, did it introduce a risk of transmission to yourself? And since then, what we also understand is that the transmission risk around COVID, put very simply, is much more about aerosol transmission. So it's much more about the virus, which is in your mouth and your nose if you got the infection, in which you're sort of potentially spreading to others. So the evidence base around face coverings is unambiguous that it does reduce the risk of transmission to others. Now, it needs to be, if you like, 3-layered sort of cloth face coverings as a minimum, sort of not wet and sort of used, etc. But it does unambiguously do that. The evidence base is also showing that it is highly probable, but not proven, that wearing a face covering also reduces your risk of catching the infection from others. But it's not as effective at protecting you as it is about, if you've got the infection, protecting others. So I guess that's kind of your 25%, 75% thing. I couldn't tell you the percentages, but it does definitely have not just a protective effect for others, but it does give you some protection as well. The other thing, obviously, is that although cumulatively it starts adding up in terms of cost, there are some types of face coverings, particularly those which are used in sort of care and hospital settings, which are, if they fit properly, and you do need to have them fitting properly, and if you change them fairly regularly, so i.e. they're for like daily use rather than continued everyday use, give you a very high level of protection. So for example, a colleague of mine was going on holiday and was really worried about the airport and the plane, and the advice I gave him was to use sort of higher grade sort of face coverings for that journey as sort of as a way to protect himself rather than necessarily being about protecting others. So there are some types of face coverings, particularly those which, if you like, the same types which are used in clinical or care settings, which do give you a high degree of protection. But the downside is that they are disposable. So it's not like you wear it for 10 minutes, you have to chuck it away. It's not like that, but it is a sense of they're not like washable and sort of sustainable. I hope that's answered your question.
Yeah, that's fine. Yeah, thank you.
Mabratu, is there anything else that you think that we need to be information-wise that would help? Because obviously you are now going to relay that to your colleagues in the sector. Is there anything else that we can do around this area that, that might help?
Yeah, this is why I raised this question. We have discussed this one about the face masking, And then we discussed as well about the key messaging as well, how we can promote, among the communities. So yes, I mean, still we need, scientific evidence, the benefit of COVID vaccine taking. So yeah, it's not an easy task, to convince the people who they don't want it themselves, yeah, but we're still struggling on that one. So it's good to have an evidence here. Thank you.
Thank you, Abratu. Gerard?
Maybe this is something sort of particularly close to my heart, since I've got a 9-year-old and a 13-year-old, but I suspect I'm not the only one. I mean, the advice around vaccinations for children seems to have sort of evolved or changed somewhat over the last few months. So, at one time, it wasn't being advised, and then it was for a certain group. And certainly, my 13-year-old has now had 2 vaccines, although that was partly prompted because he was going abroad and had fact. But I recently got the letter for the 9-year-old. I haven't done anything about it yet, or I suppose I will. But I notice amongst parents of younger children, there seems to be a sort of like, oh, I'm not sure we're really going to bother, but I presume the advice is that bothering and it is effective and useful to avoid spreading to older generations.
Thanks, Gerard. Yes, it's not, I think, one where national vaccination advice has necessarily sort of covered itself in glory, but however, we always have to be very mindful of what we know about the evidence about cost, if you like, the benefits to individuals rather than the potential for harm. So if you think back to when the decision was first made about offering first doses to our 12 to 15-year-olds, it was at the time when there was concern about myocarditis risk in mainly young men or young people. I don't want to say boys, but you know what, teenage young men, which was particularly being reported in the US. And whilst all the evidence, all the indications at that point were suggesting that this wasn't a standard sort of heart inflammation problem. So heart inflammation often is long-term persistent and very debilitating. All the indication was it was a very fleeting matter, wasn't causing lasting harm. And of course, you've got to compare that to COVID, which even in healthy young men or young teenage men also causes heart inflammation and of a longer duration. So when that advice first came out, it was on a very precautionary basis. By the time we reached the advice around the second vaccination decision, we were already clear that indeed that heart inflammation risk was lower and temporary, and therefore you could change the balance of the advice that you were giving. The other thing which is also very apparent, I think, I don't have kids, but I've got lots of friends who have kids, and obviously we work closely with schools. The level of disruption, particularly caused by Omicron in schools and to schooling, was just phenomenal. So although the vaccination doesn't give you enduring protection against transmission risk, it gives you some for a period of several weeks. And so the balance of evidence and the context change. The current advice, again, this is thinking about a infection which moves and you have to keep up with the infection, is that having the vaccination now, even though so many of our young people have had Omicron, will protect you to some extent against any other variant, because our experience about the vaccination state is that we've had enough variants to be confident, reasonably confident, beyond a real breakthrough variant, that actually immunity through vaccination will protect you against the risk of what might be a more serious variant in the future. So my advice would be, you need to think as a parent very carefully about the balance of benefits and risks, etc. But I think the balance of benefits is now clearer. The evidence about risk is also clearer, so we can be clear there's a more benefit versus the risk. And it's partly about what the health impacts are. It's also thinking about what the practical impacts on schooling. And of course, schooling impacts taken, you know, cumulatively, also have big implications for your health and well-being.
Thank you. I was looking at the stats that Manaz had put together in terms of how many of our young people in the borough have taken up vaccinations. So I was quite surprised by the take up. So for those between 12 to 15, we have an eligible population of about 8,638, and 35% of that number have been vaccinated, which I thought was high. And 16 to 17-year-olds, 3,950, of which 44% have been vaccinated. So those were as of a few days ago. And I was going to ask Anita, in terms of parents, we've got. What are you thinking about, you know, in terms of conversations with parents, if anything?
Well, you know, I mean,
Yeah.
I would suggest that we speak directly to the children, especially those older teenagers. They're perfectly capable of making the decision and or arguing with their parents about it. I think Jared's right. I think from parents' point of view, the way that it's been sold or not sold to them was that it sort of wouldn't harm them too much and would probably be good for some older people or teachers or something. And that's sort of the vague idea parents have got about children getting their vaccinations. But children themselves have been extremely concerned and worried and upset and scared about COVID all the way through. And actually, in a way, it's empowering for them to be able to have the conversations to think about and decide whether they want to do the vaccinations. And I think, you know, if we wanted to increase those numbers, or we felt that some more work needed to be done on that, but we should focus on talking to the children directly.
Actually, that resonates with what Michael was saying from St. Luke's. He was saying that in his pop-up, well, the pop-up within St. Luke's, that the vaccinations run out, and he was really surprised how many young people came by to have their vaccinations. And you know, the question was asked, how come? And he said it was the conversation with the young people. And he said they were in other settings within the community centre, and they had the conversation and they got vaccinated. So
yeah,
it really
I think
resonates with what you're saying.
Yeah, they want to get vaccinated, but it has to be really easy for them to do that. So they have to be really clear that they know when they're going, where they can go, and that they won't be like, you know, hassled or stressed when they get there, because the same as with other communities, if they rock up to do it and something goes wrong at that moment, it's very difficult to get them back afterwards. But yeah.
Does the NHS app work exactly the same for kids as well as adults? Is it?
Yeah, you can. I mean, and some places are doing walk-ins for young people as well. I mean, they have to have their adult with them, but they can do that.
In fact, our resource centre does walk-ins for 12 pluses with no appointment needed every day of the week, 10 till 3:45. So, you know, it's bang in the middle of the borough. You know, it's the resource centre, so it's, you know, pretty well as easy as you can make it.
Yeah, except they're at school most of that time. But yeah.
Sunday and Sunday. Well, you know, a lot of them aren't actually. I mean, school refusal has become such a thing since, but actually Saturday and Sunday is the point. Yeah. I'm sorry, I'm going to have to go. Apologies, everybody. I sort of had something else I booked in, like Miriam, at 6. So it's lovely to see you all. See you all again soon, I hope.
Yeah. Thank you, Sue.
Bye.
Before Jonathan, before you arrived, we were just talking about what the VCS are doing in terms of community organising. So Lucy talked about the model that they're deploying at Holloway Neighbourhood Group, so community organisers and together with volunteers, and St. Luke's and the Light Project are doing similar work. So there's going to be lots of conversations to be had there. And I just wanted to flag up that we now, with other colleagues on here, so Anita and others who haven't been privy to this. So we have lots of flyers in lots of different languages, 7 of our most widely spoken languages. So Arabic, Spanish, Somali, Urdu and Turkish, and a couple of others. So we have lots to distribute. Our faith centre sites, Ros, you've been heavily involved in with that. So we do want to get these flyers out to some of the communities, cafes, community restaurants, ethnic supermarkets, and we sent out a call out this week, as well as we did in February as well. We haven't had quite the response that I was hoping, but maybe it's because we hadn't had the flyers. So it's a call to arms. So the people on this group here have got to do it all. Got to cover the 3 wards, but no. So please do ask us, because we have flyers here and we will be getting them out to the sites, but we do need some help with that.
Thing is, with all the education, what are the reasons that people are still not? Is it still the same reasons as before? Because there's a lot more information out there, and obviously, hopefully, people are looking for it. But if it is, they are looking at the information and they're still not doing it. Are there other reasons that people are not taking up?
It's a complicated picture, is what I would say. Is that come in, anybody on this? So we've all got Miriam. Yes, go for it.
I'll just say something before I have to run. I think a lot of the reasons are the same old, and haven't changed too much. I think, ironically, with the ceasing of a lot of the restrictions and testing, and as we've alluded to today, the perception that COVID's finished. I think that is colouring some people's view about, well, I haven't bothered getting vaccinated so far, and I'm still here. And it's all stopping, so I don't need to. But of course, the reason that restrictions have been taken back, and the reason hospitalizations are so low relative to how they were at the start of the pandemic, even though we've got the same number of cases, and we've had more cases in recent months than we had at the start, but still people are not in hospital as much, people are not dying as much, is because of the vaccination. So if you're going out into that environment unvaccinated, you're in a worse state than you were in the previous months when fewer people were mixing, and there was less transmission risk. So it's a sad irony that thinking that it's over and therefore you won't get vaccinated, you're probably at more risk. And it's only because everyone else has been vaccinated that that hospitalizations and mortality is as fortunately low as it is just now. So. But yeah, so it's a patchwork of reasons in it, and it varies between groups of people.
I had to get a posting taken off Islington community group because a guy had posted that he had picked up a flyer outside the station of anti-vacciners giving out flyers, and he said, it's a fact that more people are dying because of the vaccine than not. And I had to, I had to report it to the guy who runs the Islington community group and say, look, come on, you can't have this guy putting these things on it. But because there's still people spreading that around, and they were handing out flyers outside the station. No,
it's most unfortunate, and yeah, some people are receptive to things that they read, regardless of the source. So thanks for getting it taken down. We can only hope to sort of crowd it out with decent information, I guess. On that note, I'm going to have to run.
Thank you, Miriam.
Yeah, sure. No, nice to see everyone. And my email's in the chat, so if there's anything else I can help with, please just
great.
All right.
Have a good evening.
I will. Thank you.
Jared, you have a question?
Yeah, it's slightly linked to what we're talking about. We're probably not untypical at Islington People's Rights. If you think of 30 people involved with the organisation, that's staff, volunteers and trustees, it's quite a diverse workforce. Let's say their attitude to COVID and things becoming sort of normal again, whatever that might mean, varies considerably. And I suppose, grappling to an extent with, how one makes some sort of transition towards normality. Vaccines are clearly helping. I must say on a sort of specific level, things were going okay. But then, one the staff who's got some health issues, in fact, went from sort of not doing anything to actually thinking, oh, you know, I need to have a life again, and went out and basically then got COVID, ended up in hospital. That didn't help in terms of how it was perceived, let's say. And another one started more cautiously, I think, going out and also got COVID. So it's sort of interesting because, you know, some of the people who are quite reluctant. We're not the only organisation. I suppose I'm trying to be sort of fair to everybody, but actually find it quite difficult to get a sort of, you know, an equal sort of approach to, you know, getting back to some sort of normality. I think we're getting there, but possibly more slowly than one might like. But, you know, hopefully we will, and maybe there's other specific factors, IPR.
Thank you, Jared. So what I would, sorry, going back to the flyers, we will dispatch them to you. So we've been taking Ubers across the borough and getting them off to various sites. So if you want some, please ask me and we will get them to you. Yeah. Any other, is there anything, we can finish slightly early today and let you go. Is there anything else anybody would like to just add to? Or
I'd like to say something, Navinder, if that's all right.
Yes, of course. Yes.
Just to share with you all that this week with the Faith Leads, we've been discussing putting together a video. So videos for each faith site with very specific local concerns, so for particular communities. And so what we did is we wrote to Miriam and Leona and we asked, okay, we need to sell this, so please can you list the benefits for us? And please can we have some ideas on the different platforms, for how long, and so on. So I'm actually inclined to send that to you, Navinder, because I think it will make a real difference if you have community leads doing a video like that and just saying, listen, there are still benefits of being vaccinated, and here they are.
Perfect. Yes, do, because we have a range of assets now. We have social media banners, posters, flyers, and the videos will just absolutely add to that. So yes, as soon as you have those, do send our way and we will disseminate.
I just want to respond to what Lawrence mentioned earlier. So the reasons for not getting vaccinated are really multiple, but we do have some faith sites saying that they're afraid because some of their members have had side effects. And so they've had the side effects once or through the second vaccine, and then they're put off taking any more. So I think we do need to look at side effects, and we just need to have conversations.
Actually, I'll agree with that. We've had things, we work with quite a few older people. And one of the first things they say, I had to think, I had a bit of pain and I was a bit tired afterwards. So it's fun. And you're saying to them, well, that's a natural thing. Don't worry. I mean, these things will happen. Don't worry about that. But they think it's a complete negative because something has occurred. And then that will have a natural effect on to the next going on. I think you're absolutely right, Roz. Yeah.
Thank you. Jonathan.
Thank you. So just Gerard, in terms of sort of thinking about people who are very vulnerable and remain very vulnerable, I mean, the vaccination is still highly protective, but I think that whole thing about as we go into the summer and you can think about being outdoors and the ventilation is probably one practical thing that can help. But I think the difficulty with this is that we do have a number of people who will be very clinically vulnerable, so much smaller proportion than would have been shielding, and where COVID is effectively another risk that they have. So they're vulnerable to a whole series of different infections. COVID is very prevalent at the moment, so that is a very definite risk. But I think the outdoors and the ventilation piece in particular could be something that can help people who otherwise might be feeling very alone and lonely at this particular time. But I completely get where people are with this. Just on Roz's point about the side effects, I mean, that would be one of the other reasons why people do decide they don't want vaccinations. And there's something I always think about, people making a purposeful decision about an intervention where you choose to have it versus something like an infection, which you don't choose to have, but you might catch. And there's that sort of psychology in there, which I think is just, well, human nature possibly. But the main thing I would say about the side effects that people have, which definitely do put people off, is the profile of side effects is like a very, very, very diluted COVID infection. I mean, that's a risk. I mean, even, you know, I remember talking to people about when the clotting risk associated with AstraZeneca was being identified, and people were talking about that as a risk. Even as it was emerging as risk, one of the things I could say very definitely to people, well, yes, there is a risk which has been identified. Blood clots are one of the ways in which COVID kills you. And it's much, much more prevalent in the infection than it was ever in as a vaccination risk, because we've now adjusted our vaccination approach. We're not really using AstraZeneca anymore, apart from in very exceptional circumstances. So I think that whole side effect, that balance of benefits and risks is an important one to get across. But how it feels to make a decision to have a vaccine as opposed to take your chances with the infection, I'll be clear, I think it's a one-way risk really in terms of infection now. Is one to cross, I think, and I don't have a simple message about how one gets around it, but I think that getting that clear message across about that balance of benefits and risks is important.
Thank you, Jonathan. Shall we wrap it up there and have an early evening? Well, some people might still be working after this. I suspect Jonathan might be, but I hope not. Okay, so thank you, everybody. Really interesting, as always. Thanks, Jonathan, for all your information. It's always superbly put together and articulated to us.
Well, I have to say thank you to all of you, because all of your work, keeping the conversation going, it's the best thing we can do at the current time. Yeah. Even if it doesn't translate into lots of people in the short term getting vaccination, we will almost certainly have more vaccinations in the autumn and winter. It's really important to maintain that. So thank you all to you as well.
Thank you. And I was encouraged by the stats that actually there's still only 91,000 people in the borough to vaccinate. So that's encouraging, because it was somewhat 4 or 5 months ago, it was 150,000 or something. So we're getting there.
And I'll be clear, there's quite you've engaged my data, Anna, right now. So depending upon which population we use, that figure is anywhere between about 60,000 to 90,000.
Oh, this is the uptake of the first dose vaccination. Yeah. So people who have had none. Yeah. Oh no, uptake of first dose vaccination. Yeah, so unvaccinated is 91,269. There you have it. Thank you, everybody. So yeah, come to me if you want your flyers Ubered over to you. Yeah. Okay. Thank you. Have a good evening, everybody.
Bye. Thank you. Bye.
Bye-bye.
Bye.